And next up, we have Vanessa Vera, who is here in Miami. And as we heard, that GI issues are very prevalent at FOXG1. So Vanessa is going to talk to us all about these things that we are constantly speaking about in the parents group, constipation, reflux. So I sense a lot of questions will come as well. There's stairs here. Thank you so much for joining us.
Thank you. Thank you. What an honor to be here. It's been an amazing experience so far. Okay, so we decided to name this Digestible Tips for FOXG1 GI issues. And in truth, I can tell you I can speak of this for hours and hours and hours, and I try to compress and as much as possible, but I'm sure we're gonna have a million questions, and there's absolutely no way that I can cover everything in only 15 minutes. So digestible tips, little background. I am a nurse practitioner. I currently work at Pediatric Gastroenterology Associates, and we're located at Nicholas Children's Hospital here in Miami. I only had a 1-hour drive to come here. I love the city, and I'm super happy to be here with you. So we are going to cover, where do I point this to? Thank you. So we're going to talk a little bit about reflux, constipation, and I'm going to go over tube feedings and feeding difficulties. Okay. So why are GI issues, or why do children with FOXG1 are very susceptible to having GI issues? It can be because of the low muscle tone that can cause a little bit of slow motility, but it can also be because of high muscle tone and abnormal movements that can cause diaphragmatic movements that can worsen reflux, for example. And most of all, it's side effect of medications. Like most of the neurological meds that our children have to be on cause any side effect of a GI. It can be diarrhea, but most likely what we usually see is constipation. And reflux. Reflux is the passage of gastric content up into the esophagus, and sometimes it can be spit up. Okay, so what are signs of reflux? Constant spit ups. If your child is constantly spitting up, evidently gastric content is coming up. But also back arching, and this has an anatomical reason, and what happens is that when you back your arch, you're elongating your esophagus, okay, so that the gastric content has a harder time to come up, okay, so that is like a normal way of finding relief for reflux. So the first question that any GI doctor is gonna ask you is if you see that behavior, if they find comfort in a back arching position. And irritability, of course. If any of you has ever had a heartburn, you know how uncomfortable it can be, okay? And then since some of your children cannot express, oh, I have a feeling of something hot coming up my esophagus, then irritability, we need to assume that one of the causes can be because of reflux. And then difficulty feeding and poor weight gain. So irritability in your esophagus causes pain, and then when you eat, that can cause a little bit of pain. So sometimes they refuse to eat. And if they refuse to eat, then you can see that there's poor weight gain, and then you sometimes see that your child has been in a growth curve always on whatever percentile your child is, on the 3rd, on the 10th, on the 50th, and then they slowly start what we call crossing percentiles that you can see over here. So this children is on a certain curve, and then suddenly they start crossing percentiles, and that is a sign of alarm. Now we talk about C-score, and your child should always be on the same C-score. The regular is -1 to 1, but if it's a little under, that's okay, as long as he's always on the same C-score. Okay, if he's gaining weight, but his C-score is dropping, then he or she is not gaining enough weight. And then nutritional consequences happen because of that. And that, sadly, the only way that we know absolutely for sure, the only objective measure that your child is well nourished is because of the weight gain. And then here is a little bit more about house reflux, and it's caused because then the lower esophageal sphincter that's here, it should be able to close and prevent the gastric content to come up the esophagus. But when this lower esophageal sphincter, or LES, opens up, it allows the fluid to come up. Okay, and all babies have reflux, and all of us have reflux. It's depending on the amount of reflux that happens that it becomes harmful, because the stomach is made for the gastric content, for acidic content, but the esophagus is not. Okay, so if you have an esophagus that's constantly exposed to acid, it's an esophagus that's going to get irritated and sick, and if it's irritated, it's going to be causing more spasms, so you're going to have more reflux. Okay, so what can we do about reflux? There's pharmacological measures and non-pharmacological measures. Obviously, we first take the approach of the non-pharmacological, and one thing that's super easy is the thickened feeds. So the thickened feeds, it does not diminish the reflux, but it does diminish the amount of emesis, okay? So even though if it's not gonna diminish the reflux that you cannot see, if your child is throwing up 5 times a day, and now because you thicken the feeds, he only throws up twice, I will take it. Then positioning. Evidently, gravity, if you're in a vertical position, the fluid stays down, the air comes up, and one of the recommendations is for your child to be sitting up for at least half hour after you feed it. Do not overfeed. Do not overfeed, because if you overfeed, the capacity of your stomach to hold that fluid, evidently a full stomach is going to be able to reflux more into the esophagus. Formulas. So there's a few approaches to formulas. Nowadays, there's a recommendation for you to trial cow milk-free formula, because sometimes it's not reflux, it's cow milk protein allergy. So you can trial 2 to 3 weeks without cow milk, and if the reflux is better, then it really wasn't reflux, it was just a cow milk protein allergy, and then it wasn't such an easy fix. Then some formulas, like the peptide formulas or the amino acid-based formulas, are a little bit easier to digest and improve reflux. And then you have your classic medications. You have medications to decrease the acidity of your gastric content, okay? And it's important to know how it works. It will not diminish the amount of reflux coming up, but it will make that reflux less acidic, so that when it comes up, it doesn't harm the esophagus, okay? And then there's motility agents that can help speed the gastric emptying, so that if the stomach content gets out into the intestine faster, then there's less content in the stomach to come up and cause that reflux. And then medications for spasticity control, that we just said that not a lot work, but when you diminish that spasticity, then you're diminishing the pushing up the contact into the stomach. So always know how your medication work, so that your expectations are real, okay? And then if everything fails, you do have some surgical options, and the surgical options, it can make this LES be a little tighter, so that the fluid or the gastric content doesn't come up. And that is an infant application. And what basically they do is wrap the same stomach around the esophagus, and it creates like a tight seal in the LES and prevents the liquid to come in. The infant application, I rarely see it without an accompanying G-tube. So we're going to talk about G-tubes later. So if you're making the decision about going to a G-tube, maybe it's time to inquire if alongside the G-tube you can do a fund application. And before you make up that decision, there's a way of knowing if it's really going to work, and this is jejunal feeding. So basically you bypass the stomach, okay? You need a G-tube for that, and you convert the G-tube into a JJ tube, okay? And it has a port that you can give medications to the stomach, but then it has a different port that goes into the jejunum. You basically bypass the stomach, there's no stomach contact, there's no reflux. So in my experience, what we do recommend is if you're thinking about doing a fund application, you can do a trial with jejunal feedings first, and if it works, most likely a fund application is also going to work. The thing with the G feeds is that you have to exchange them every 3 months. So if you don't want to be coming in and out of this hospital every 3 months to exchange a G tube, a GJ tube, maybe you can consider a surgical option. So first digestible tip is one change at a time. You need to find what really works. If you make 3 changes at a time, you really will not know what was making the difference. And then you may be sparing yourself from medication or something. If you're gonna change the milk, observe for 2 to 3 weeks. If it works, then bingo, that's it. You don't have to do anything else. If you're gonna add medication, you're gonna add 1 medication at a time. Everything, of course, guided by your GI doctor. And take it. And sometimes it's frustrating because you need to have the right combination, and maybe the time that we're working, it doesn't work out for you, but it's true, it's in your child's benefit, because we want to achieve the best response with the less amount of medication and the less amount of non-pharmacological treatment. Then constipation. Okay, and constipation, the definition or the signs of constipation, first of all, is frequency. And in general terms, what we usually say in our office is your child can be stooling from 3 times a day to 1 time every 3 days, and that might be normal for your child. The frequency is not as important as the consistency, okay? Because if your child is pooping every single day, but it's really hard balls that are really hard to push, and it's accompanied with streaks of blood, then it's a constipation. But if your child is pooping every 3 days and it passes easily and it's pasty and soft, then that's not considered constipation. The other is impaction. When your child spends too many days without going, every day that the stool remains in the colon, it dries up. So the longer the stooling is in the colon, the drier it's gonna get. And it can accumulate in the rectum, and it can create like a huge mass of poop that then it's too hard to push out, because you have a mass this big trying to come out a hole this big. Okay, so it stays there, and if the longer it stays there, the harder it becomes. So sometimes you can tell that your child is constipated if it has impaction. You can even feel it in the bottom of your abdomen. You can actually feel a mass. I'll go back to the microphone, but I wanted to. And then distension. Okay. Evidently, you don't need to be necessarily impacted to be distended. But the abdominal distension, it can be gases, it can be a combination of gas and stool, but the thing is that when you're distended and when it slows down, it even slows down the motility, your general GI motility, so you become irritable because it's painful. And we've all had gas, and it's painful to have it. And then what happens is that it's sending a signal to your entire GI, and it's saying, hey, you stop moving. We stop moving because easily there's nothing that fits here. So your child is not gonna wanna eat. They decrease the amount of PO. They fed up easily, so 2 spoons and then that's it. And it's because simply you need to get rid of everything that's in there to be able to accept more food. And then because of the decreased appetite in the early society, then again, you start losing weight, or you're not gaining weight as much as you should. So what can you do about constipation? There's not evidence that you need to increase the amount of water and fiber. You do need to have a regular amount of fiber in your diet and water in your diet according to your child's age and weight. Motility in this case, more mobility. So movement, any changes in position, physical therapy, moving, changing places, going from the bed to the chair to the bed to the wheelchair, activities at school, any type of activities and movement, it's gonna help with motility. Again, trial of cow milk protein. We see in babies, the first sign of cow milk protein allergy is constipation. So when a child presents with constipation, after I have ruled out all the red flags and like the real serious colonic issues such as Hirschsprungs, a trial of cow milk protein usually takes care of it. And also the milk products cause constipation. So cheese and milk, it naturally causes constipation, so diminishing it usually helps, or changing to a vegetable, plant-based formula can also help. And then we need to prevent impaction, because think of a balloon. When you have a brand new balloon, it's kind of hard to blow it up. But once it deflates and you try to blow it up again, it's super easy. So that's what happens with your rectum. This is your rectum, and it fills up a little bit with poop, and then it gives you a signal to poop. But if you blow it up and you cause impaction, once you get rid of the impaction, the walls of the rectum are going to be fluffy, and they're not going to have the same contractibility that it had before. So usually, after an episode of impaction, we need to look back and change completely the regimen that we were on. So if you get into an episode of impaction, you need to do a thorough clean out, which means like huge doses of Miralax and go lightly, sometimes through an NG, sometimes it happens in the hospital, because it's the only way to get rid of that. So little by little, it breaks it down, and then you start pooping practically clear. And you need to make sure that the impaction is resolved, because if not, the maintenance medication is not going to be effective. Okay, so at all costs, we should prevent our child to get impacted, because then it's a whole at least 6 months for that rectum to regain its elasticity and strength. So now in this case, I am going to go directly to medications. I usually, prune drop juice is not a medication, but if your child is not on a keto diet, and that's usually first thing that we try, and it helps. And then you have the stool softeners or the osmotic laxatives, which basically what it does is it makes the stool softener. It brings water into the rectum, and it makes that stool softener. Remember, the more time the stool remains in the colon, the harder it's going to get. But if you have medication like Miralax, whatever comes in, comes out in the same way. So if you mix Miralax 4 ounces of water, that Miralax is not going to get absorbed. It's going to stay in the colon, and it's going to maintain that stool moist, so it's easier to pass out. The Miralax is currently, the Miralax is the #1 medication recommended by NASP again. The second one is lactulose when the Miralax is not available. The thing that I like about the Miralax is that you already mix it in enough water. Okay, so the lactulose, the mineral oil, the milk of mag, draws additional water into the colon, so you have a higher risk of dehydration. The stimulants, like Senna or Bisacodyl, it just causes the intestine to contract. Okay, so after an impaction, Miralax by itself is not going to be enough. You need a stimulant for at least 2 months or even longer to help get rid of, to help evacuate the stool. And then suppositories and enemas are not recommended for maintenance treatment because those do cause dependency. Some very complicated cases of constipation, we may have to do retention enemas, but we try to avoid that as much as possible. And motility agents, there's conflicted information as well, conflicted data as well. It is really not recommended as a standard use to prevent constipation, medications such as erythromycin or Reglan. It is used more for reflux, but are not exactly for constipation. There are other novel drugs that are being used for IBS constipation that might be worth doing a trial for FOXG1 kids, but I don't have data at this moment. So second digestible tip, the key is finding the right maintenance treatment. Whatever it is, whatever works for you, we need to do something or medication, any type of combination between medication that allows your children, maybe not to go every single day, but at least once or twice a day. And like we discussed, it has to be easy, so easy to pass, and don't present any of the other complications. And now 2 feedings, one is a time, and this is the hardest decision that the parents of my patients get to make. And on the most part, after they make that decision, usually it makes their life easier. So this is the picture of a swallow study, okay? So feeding difficulties. If your child has, and it's seen a lot in FOXG1 children, like we just saw, if they have difficulty chewing, if they have difficulty swallowing, if there's not really good swallowing, a suck and swallow reflex, that's a reason to consider a G-tube. But aspiration of thin liquids, or sometimes aspiration of all consistencies, then it tells you that you cannot. So if you have in a video fluoroscopy aspiration of thin liquids, what happens is that the liquids, instead of going to your stomach, they're going to your lungs. So what's going to happen is that your child is going to have aspiration pneumonia. Okay, and constant aspiration pneumonia causes fibrotic tissue in the lungs, and we're gonna have a discussion on respiratory issues right now, but after a while, you're gonna create a resistance. You're gonna create oxygen dependence because your lungs are gonna stop working. So, aspiration of thin liquids. You can consider giving thickened feeds, yes, but I find it that with time, it's hard for the parents to comply with the required amount of liquid that your child needs if you need to give everything thickened. Lack of weight gain. If they don't have enough strength to eat what they need to eat to gain weight, you need to consider a G-tube. And then difficulty giving meds. If you have to give 3, 4, 5 meds a day and they don't like the taste and it's a struggle to give meds, you're creating more aversion. Your child is not going to want to eat. Okay, so even I don't think that just because of the medication is enough to make the decision of putting a G-tube, but it is going to help once you have the G-tube in, because you are going to start feeding by pleasure. You're going to start feeding because you want that with your child, and then you can guarantee that his nutrition needs and his medications need are met through the G-tube. And the G-tube, it looks like this on the outside. You have a longer one that's like this that usually they put. It's surgically inserted percutaneously, and it's fairly nowadays a very easy insertion. It's a short procedure. It is painful for the first 48 hours especially, but then the child doesn't really feel it. Most of the complications, aside from the surgical complications, most of the complications happen during the first year. So after the first year, there's usually not a lot of complications, and most of the complications are over here, like either granuloma tissues on the side, or it can be side infections, cellulitis. But the important thing is after you're past that, after the year, you don't see much of complications. And then GJ tube is just like a version of the G tube. It has a port for the G and a port for the J, because importantly, the medications cannot be given through the jejunum, and they have to be given through the G. Okay, so you would feed for over here, which is the jejunal port, and there, and you would give medications through the J. Okay. And then the digestible tip number 3, there should not be stress in feeding. If you're dreading the moment to feed your child, then you need to consider options. Okay, if your child is not gaining enough weight, which is our only objective measure of nutrition, then you need to consider other options. Feeding should be a pleasurable moment. Feeding should be nice for you. It's the time to connect with your child. And if you're still being, and sometimes I understand that we can't feed by mouth if the child is aspirating everything, but if you are able to feed by mouth, it should be a moment to connect with your child. It should be a nice moment. And then digestible tip number 4 is follow your instincts. Nobody knows your child better than you. You know what works for them. Do one thing at a time. Find out the best combination. Have an open discussion with your doctor. It should be a common decision between your doctor, your GI doctor, and you what medications is. We recommend whatever's scientifically proven, but if there's something that works for you, we should be open to discussion. You should be heard. And then my final digestible tip is things change. Sometimes you are a long time on a certain reflux medication, on a certain constipation regimen, and then it stops working. And things change. Your child is growing. The needs of your child are different. So don't get stuck on the idea that this has always worked. No, sometimes things stop working, and then it's time to make changes. And the fact how fast things change are also a clue. If things change gradually, it might just be that your child is growing. If things change abruptly, then there might be something different going on that we need to evaluate. An open discussion, I guess, is going to be after the other talks.
I think we should do it now, so it's fresh in everyone's mind.
Okay.
So, yeah, thank you so much for.
Thank you.
I think talking poop is one of our community's favorite topics. And we love the emojis. So do we have any questions?
What's a poop talk without a poop emoji?
A couple days ago, our GI mentioned possibly going off of Prilosec due to the long-term side effects and risk. What are your thoughts on that?
You can. There's recent data that says that there's a higher chance of gastric cancer with long use of H2 blockers. You can definitely trial off. I would switch to a H2 blockers such as PPI. I'm sorry, the data is with PPI, not to H2 blockers. PPIs are lansoprazole, omeprazole, Nexium or esomeprazole. Those are your PPIs, proton pump inhibitors, and it's the strongest medication there is to acid control. And then there's the H2 blockers, which are the Pepcid, the famotidine is the one that's most commonly used right now. I think it's reasonable to trial off. I would switch to Pepcid for a while, and they can be on and off. In truth, most of our children remain on PPI because it's a risk and benefit thing. And if your child is miserable and irritable without the medication, then you need to consider the risk. The risk is still very, very low amongst the regular population. So you have to discuss it with them, but I think it's definitely worth a try.
Sorry, I actually have two questions. Most of the medication, it always says to mix with water, like Miralax, for example. We tend to put it in the food because it's just easier for him to, like in every breakfast, he has like a bowl of fruit with oatmeal. Does it make a difference from the effectiveness of the medication?
It does. It does. It's less effective if you mix it with solids. It's more effective if you mix it with clear liquids. However, you can go a little bit, if it's working for you, what we generally do is like we go a little bit higher on the dose. But the thing is you need to guarantee the Miralax by itself, it does not work if you not give with enough liquid. So if you're gonna give with anything, with yogurt, for example, then follow it with water. Try to make sure that during the day, she or he drinks enough water during the day. Okay.
And water or milk, does it make, like, could you mix it with milk or it has to be
milk?
water?
Yeah, with milk is less effective.
So it
So
has to be
when, and I do have a lot of parents that they just don't drink with clear liquids. Well, first because our options of clear liquids are juices, and then sometimes that's contraindicated, or water, and then some children don't like the taste of water. So on our kids that we give it with milk, sometimes we just have to go up a little on the dose of Miralax.
And then my second question was about the aspiration. So we've never had an official swallow study done, but he has been eating for 2 years now salt puree. And he's never had any lung infections. We've done an X-ray of his lungs and it was completely clear.
Mm-hmm.
Would you then still recommend the swallow study, or if everything
So
is clear?
if it's fine, what signs do you have that you might be aspirating? He's coughing, okay, when he eats, okay, coughs a lot. It happens to us. We eat and then something goes the wrong way and we start coughing like crazy. But if that's a repetitive, like 2 or 3 times while he's eating, then you think you have to suspect that there's any sign of aspiration. How the swallow study works is they give different consistencies by mouth, and they see how it goes and how it. They can tell you. Sometimes they don't have aspiration, but they have penetration, inconsistent penetration, which is normally it might turn into aspiration, or there's a high risk of aspiration. So it's a very comprehensive study, but if your child has no feeding difficulties, I don't think it's necessary unless the speech therapy evaluates and says that it is.
Hi, I'm Jessica Erkman. I'm actually speaking next on pulmonary concerns. So there's a lot of misconceptions, and I will talk about this in relation to aspiration. And very often, you should not use the absence of certain clinical features to assume that your child is not aspirating. Very often, these children will have normal chest x-rays. You don't get frank aspiration pneumonia unless you are aspirating a massive amount of food or liquid or gastric contents. What's more damaging is the accumulation risk of what we call microaspiration. And you tend to get bronchitis, aspiration-related bronchitis. And very often, particularly in neurologically impaired children, the only sign is a little bit of cough. And sometimes it's that cough just once a day. So in most of these children who have hypotonia, we do recommend a swallow study. because the signs and symptoms that your child is aspirating or having trouble feeding by mouth are very, very subtle and easy to miss.
I think my question is for both you and maybe Dr. Banky at the same time. So I rely on the world of parents on social media to learn so much, which is so great. And I know you all are the experts, and the ones in this room and the ones that we have on our team, luckily I trust a lot. But I would love, at one point there was like a big thing going around about the negative impact of long-term Miralax, especially on like neurological aspects. And so Corbin, that's what he uses, that's what's effective for him. And so I just want to hear from you two in the room, like what is your take on that fear that some parents have about the impact of Miralax?
Mom is against Miralax. It is a favorite phase. I have not encountered enough data to say that Miralax is harmful. It is still the #1 medication recommended by NASPGHAN. It is a large molecule. It is a large molecule that does not get absorbed in the intestine, so whatever comes in comes out. And it's so safe that we give it's a medication of choice right now for colonoscopy preparations, and it's usually the medication that we use mostly in our practice.
I don't have any concerns about long-term use of Miralax. I'm with her.
Bram?
I have a question about G-tube. Have you seen the G-tube being removed again by many patients after, let's say, they start
Yeah,
eating
you just
better?
pull it out and it closes up. It's
No,
the
but I mean,
easiest
after they
thing.
start eating better again and they become more normal and it's not needed anymore?
Our general rule to recommend a G-tube removal is that you don't use it at all, not even for medication, for at least 3 to 6 months. Not in FOXG1 children. I do. It depends on the neurological condition if it gets better or not. But that's the general 3 to 6 months without any use with good weight gain.
I got one. What about treatment of excess gas? I think oftentimes when my son cries a lot, I think he's swallowing air.
Mm-hmm.
It's kind of this negative feedback loop. He swells up.
So you need to make sure why is he producing gas. Sometimes it's lack of disaccharids or disaccharide deficiency, such as lactose or lactase, or other type of enzymes. Some sugar produces when you don't have the ability to digest sugar well, you can produce a lot of gas. So there's two approaches: either limiting the production of gas in the gut, okay, or limiting the production of gas in the dust. And then there's some medications that help you get rid of the gas with like movement or use of simethicone. I really don't think it does that much, but it does require a whole evaluation. Like there are breath tests that you can see how it behaves. There's even some incidents of SIBO if you have slow motility. It's like small bowel or bacterial overgrowth, and that needs to be treated with antibiotic. It's a very broad range.
Are there dietary FODMAPs diet?
You can try a FODMAP diet. I think everything is it should be an individualized therapy. Like you need to tell you what, like you can do a diary and say what foods, like trial and error, what foods cause more gas and what goes. You can do an elimination diet and then start introducing foods one at a time. There's a bunch of stuff that work, and eventually if you can do the breath test, or you can even do an endoscopy and you take the saccharides levels and see if there's any deficiencies.
Thank you so much, Vanessa.
My pleasure.
Vanessa will be joining us on one of our FOXG1 Parents Connect Zooms, so we'll be able to talk poop for hours. Thank you so much.